Hi friends, this video series is to help students pursuing medical and medical allied courses. Today we will talk about the applied physiology part of movements of gastrointestinal tract, chapter 43 from Sembulikam's book. This is the part 2 of the video. Important questions for examination and frequently asked viva questions are discussed at the end of the video. New terminologies and concepts out of the area is done after the reading. Make sure you like and subscribe to the channel for the follow-up. When it comes to applied physiology, first one is dysphagia, that is difficulty in swallowing. Causes of dysphagia are mechanical obstruction of the esophagus due to tumors, switches, diverticular hernia, that outpushing of the walls, etc. Then decreased movement of esophagus due to neurological disorders such as Parkinsonism. Muscular disorder leading to difficulty in swallowing during oral stage or esophageal stage. Second one, esophageal eclasia or eclasion cardia. Eclasion cardia or esophageal eclasia is a neuromuscular disease characterized by accumulation of the food substance in the esophagus preventing normal swallowing. It is due to failure of the lower part of esophageal or cardiac sphincter to relax during swallowing. The accumulated food substances causes dilation of the esophagus. Features of esophageal eclasia: dysphagia, chest pain, weight loss, and cough. Now, gastroesophageal reflux disease (GERD). This is a disorder characterized by regurgitation of the acidic gastric content through esophagus. This content flows from the pharynx, that is, flows from the stomach into the esophagus and maybe to pharynx or the mouth. This is due to weakness or incompetence, that is failure to constrict of the lower esophageal sphincter. Features are heartburn or pyrosis, that is painful burning sensation in the chest due to regurgitation of acidic gastric content into the esophagus. Esophagitis, the inflammation of esophagus. Wherever there is phagitis, itis, it indicates inflammation. This is said in the textbook of general anatomy. Now, third one, dysphagia. Fourth, cough and change in voice. Esophageal ulcers or cancers, that is in chronic cases alone. Now, when it comes to movements of stomach, activities of our smooth muscles of the stomach increases during the gastric digestion when stomach is filled with food and when the stomach is empty. There are many types of movements of stomach, especially three: hunger contraction, receptive relaxation, and peristalsis. What is hunger contractions? Hunger contractions are movement of the empty stomach. These contractions are related to the sensations of hunger. Hunger contractions are the peristaltic wave superimposed over the contractions of gastric smooth muscle as a whole. This type of peristaltic wave is different from the digestive peristaltic contraction. The digestive peristaltic contraction usually occur on the whole body and pyloric part of the stomach, but peristaltic contractions of empty stomach involves the entire stomach. Hunger contractions are of three types. As the intensity increases, it varies from type 1, type 2 to type 3. Type 1 hunger contractions are the first contraction that appears in an empty stomach when the tone of the gastric muscle is low. Each contraction lasts about 20 seconds. The interval between contractions is about 3 to 4 seconds. Tone of the muscles does not increase between the contraction. Pressure produced by these contractions are about 5 cm of H2O. Type 2 hunger contractions appear after this, that is when the tone of the stomach is stronger and tone increases in the stomach if the food intake is postponed. Even when after appearance of type 1 contraction, when food is not given, these appear. Each of the type 2 contraction lasts about 20 seconds like type 1 contractions, but pause between the contractions is decreased. Pressure produced increases to about 10 to 15 cm of H2O. Type 3 contractions are like incomplete tetanus. These contractions appears when the hunger comes severely and the tone increases to a greater extent. Type 3 hunger contractions are rare in man as the food is taken usually before the appearance of these contractions. These contractions last about 1 to 5 minutes. The pressure produced by these contractions increases to 10 to 20 cm of H2O. When the stomach is empty, the type 1 contractions occurs first, followed by type 2 contraction. If the food intake is still postponed, the type 3 contractions appear as soon as the food is consumed. These contractions disappear. Now, what is receptive relaxation? Receptive relaxation is relaxation of the upper portion of the stomach when the bolus enters the stomach from the esophagus. It involves the fundus in the upper part of the stomach. Its significance is to accommodate food easily without any increase in pressure inside the stomach. This process is called accommodation of the stomach. Nothing but whenever food is taken, it has to be entering the stomach. If the stomach is having other movements during the entry, it may not have any easy entry to the stomach. So that time there is a relaxation of the stomach muscles. Now, what is peristalsis? When the food enters the stomach, peristaltic contractions or peristaltic waves appear in a frequency of 3 per minute. It starts from the lower part of the body of the stomach, passes through the pylorus till the pyloric sphincter. Initially, the contraction appears as a slight indentation on the greater or lesser curvature and travels toward pylorus. The contraction becomes deeper when traveling. Finally, it ends with the constriction of pyloric sphincter. Some of the waves disappear before reaching the sphincter. Each peristaltic wave takes about 1 minute to travel from the point of origin to the point of ending. This type of peristaltic contraction is called the digestive peristalsis because it is responsible for the grinding of food and mixing them with gastric juice for digestive activity. Now let's talk about emptying and filling of the stomach. What is filling of stomach? While taking the food, it arranges itself in the stomach in different layers. The food first eaten in place against the greater curvature in the fundus or the body of the stomach. The successive layers of food particles lie nearer the lesser curvature until the last portion of food is eaten and lies near the upper end of the lesser curvature adjacent to the cardiac sphincter. The liquid remains near the lesser curvature and flows towards the pyloric end of the stomach along a V-shaped groove. This groove is formed by the smooth muscle and is called the meninges. But if a large quantity of fluid is taken, it flows around the entire food mass and is distributed over the interior part of the stomach between the walls of the stomach and the food mass. Emptying of the stomach. Gastric emptying is a process by which the chyme from the stomach is emptied into the intestine. Food that is swallowed enters to the stomach and remains there for about 3 hours. During this period, digestion takes place. Partially digested food in the stomach becomes the chyme. What is chyme? It is the semi-solid mass of partially digested food that is formed in the stomach. It is acidic in nature. Bolus is the food particles in the mouth mixed with saliva. When it enters the stomach, it becomes acidic and it is called chyme. And acidic chyme is emptied from the stomach into the intestine very slowly. It takes about 3 to 4 hours for emptying of chyme. This slow emptying is necessary to facilitate the final digestion and take a maximum, that is about 80% absorption of the digested food materials from the small intestine. Gastric emptying occurs due to peristaltic wave in the body and pyloric part of the stomach and simultaneous relaxation of pyloric sphincter. Gastric emptying is influenced by various factors. Let's say about the factors. First, volume of gastric content. For any type of meal, gastric emptying is directly proportional to the volume. If the content of the stomach is large, a large amount is emptied into the intestine rapidly. Second, consistency of gastric content. Emptying of the stomach depends upon the consistency, degree of density of the content. Liquids, particularly the inert liquids like water, leave the stomach rapidly. Solids leave the stomach only after being converted into fluid or semi-solid, and undigested food particles are not easily emptied. Chemical composition. Chemical composition of the food plays an important role in emptying of stomach. Carbohydrates are emptied faster than proteins. Proteins are emptied faster than fats. Thus, fats are emptied very slowly. Now, pH of the gastric content. Gastric emptying is directly proportional to the pH of the chyme. An osmolar concentration of the gastric content is another factor, where gastric content, which is isotonic to blood, leaves the stomach rapidly than the hypotonic or the hypertonic content. Now, regulation of gastric emptying. It is by nervous and hormonal factors. We'll talk about this in the next video, because it's almost 10 minutes. Maybe getting bored, right? Or we'll finish this off. Now, nervous factor. Nervous factor which regulates the emptying of the stomach is the enterogastric reflex. Enterogastric reflex, what is it? It is a reflex that inhibits gastric emptying. It is elicited by the presence of chyme in the duodenum, which prevents further emptying of stomach. Mechanism of enterogastric reflex. Presence of chyme in duodenum causes generation of nerve impulse, which are transmitted to stomach by the intrinsic nerve fiber or of GI tract. After reaching the stomach, these impulses inhibit emptying. Impulses from duodenum passes via extrinsic sympathetic fibers to stomach and inhibit emptying. Some impulses from duodenum travels through afferent vagal fibers to the brainstem. Normally, brainstem neurons send excitatory impulses to the stomach through afferent vagal fibers and stimulate gastric emptying. However, the impulses from duodenum inhibit these brainstem neurons and thereby inhibit gastric emptying. Factors which initiate enterogastric reflex: duodenal distension, irritation of the duodenal mucosa, acidity of the chyme, osmolality of the chyme, breakdown products of protein and fats. Hormonal factors. When an acid chyme enters the duodenal mucosa releases some hormones which enter the stomach through blood and inhibit the motility of the stomach. Hormones inhibiting gastric motility and emptying are vasoactive intestinal peptide VIP, gastric inhibitory peptide GIP, secretin, cholecystokinin, somatostatin, peptide YY. Now, applied physiology, that is abnormal gastric emptying, are gastric dumping syndrome. Gastric dumping syndrome or rapid gastric emptying is the condition characterized by series of upper abdominal symptoms. It is due to the rapid or quick dumping of undigested food from the stomach into the jejunum. It occurs in patients following partial gastrectomy, removal of the stomach, or gastroenterostomy, gastric bypass surgery. The rapid gastric emptying may begin immediately after taking the meals, that is early dumping, or few hours after taking the meals, that is late dumping. Causes are gastric surgery. Zollinger-Ellison syndrome, that is a rare disorder due to the severe peptic ulcer and gastrin secreting tumor in pancreas. Symptoms of early dumping are nausea and vomiting, bloating, increase in the abdominal volume with feeling of abdominal fullness and tightness, diarrhea, sweating and weakness, fatigue and dizziness, fainting and palpitation, sensation of the heartbeat. Now, symptoms of late dumping are hypoglycemia, sweating and weakness, dizziness. This does not give you a complete good digestion. That is the reason we come across such problems. Now, next one is gastroparesis. It is a chronic disorder characterized by delayed gastric emptying. It usually occurs as a secondary disorder precipitated by primary cause like diabetes mellitus, post-surgical complications, motility disorder, gastric infection, metabolic and endocrine disorder, decrease in mesenteric ganglia, which is very rare, And symptoms are early satisfying full feeling of full with small quantity of food, nausea, vomiting, bloating, and also upper abdominal discomfort. Now let's talk about vomiting. Vomiting or MIS is abnormal emptying of the stomach and the upper part of the intestine through esophagus and mouth. Causes of vomiting are presence of irritating contents in GI tract, mechanical stimulations of pharynx, pregnancy, excess intake of alcohol, nauseating sight, odor, or smell, unusual stimulation of labyrinthine apparatus, as in the case of seasickness, air sickness, car sickness, or swinging. Abnormal stimulation of sensory receptors in other organs like kidney, heart, semicircular canals, or uterus. Drugs like antibiotics, opiates, etc. Any GI disorder or acute infections like urinary tract infection, influenza, etc. Metabolic disturbances like carbohydrate starvation and ketosis, pregnancy, that is during pregnancy, ketosis, and uremia, ketoacidosis, which happens during diabetes, and hypercalcemia. Now let's talk about the mechanism of vomiting. The first thing that comes is nausea, that is, vomiting is always preceded by nausea. Nausea is an unpleasant sensation which induces a desire for vomiting. It is characterized by secretion of large amount of saliva containing more amount of mucus. Retching, strong involuntary movement in the gastrointestinal tract, which starts even before the actual vomiting. These movements intensify the feeling of vomiting. This condition is called retching, trying to vomit. The vomiting occurs few minutes after this. The act of vomiting. The act of vomiting, there are series of movements involved in the GI tract. Sequence are beginning of antiperistalsis, which runs from ileum towards the mouth through the intestine, pushing the intestinal content into the stomach within few minutes. Velocity of antiperistalsis about 2 to 3 centimeter per second. Deep inspiration followed by temporary cessation of breathing. Closure of epiglottis, then upper and forward movement of larynx and hyoid bone. Elevation of soft palate, contraction of diaphragm and abdominal muscles with a characteristic jerk, resulting in elevation of the intra-abdominal pressure. Compression of the stomach between diaphragm and abdominal wall, leading to rise in intragastric pressure. Simultaneous relaxation of the lower esophageal sphincter, esophagus, and upper esophageal sphincter. Forceful expulsion of gastric content, that is called vomitus, through esophagus, pharynx, and mouth. Movements during this act of vomiting through the vomitus, that is materials ejected during vomiting, to the exterior through mouth. Some of the movements play important role by preventing the entry of the vomitus through other routes and thereby prevent the adverse effects of the vomitus on many structures. Such movements are closure of glottis and cessation of breathing prevents entry of vomitus into the lungs. Elevation of soft palate prevents entry of vomitus into the nasopharynx, and larynx and hyoid bones move forward and upward and are placed in this position rigidly. This causes a dilation of the throat, which allows free exit of vomitus. Now, what is vomiting reflex? Vomiting is a reflex action. It is not completely voluntary. So, the sensory impulses for vomiting arise from the irritated or distended part of the gastrointestinal tract or other organs and are transmitted to the vomit center. Where is the vomit center? That is in the medulla oblongata. So, through vagus and sympathetic afferent fibers. and vomiting center is situated bilaterally in the medulla oblongata near the nucleus tractus solitarius. Motor impulses from the vomit center are transmitted through 5, 7, 9, 10 and 12 cranial nerves to the upper part of GI tract and through spinal nerves to diaphragm and abdominal muscles. Center for vomiting during motion sickness or vomiting induced by drugs. They are different. So let's talk about that. Center of vomiting during motion sickness and vomiting induced by drugs such as morphine, apomorphine, etc. is on the floor of the fourth ventricle. This area is called chemoreceptor trigger zone. During motion sickness, the afferent impulses from the vestibular apparatus reaches the vomiting center through the zone. Center for psychic stimuli induced vomiting. Whereas its center for vomiting due to psychic stimuli such as nauseating odor, sight or nose is in the cerebral cortex. Now, movement of small intestine. Movements of small intestine are essential for mixing the chyme with the digestive juice and propulsion of food and absorption of food also. Types of movements in the small intestine are mixing movements and propulsion movements. Then comes peristaltic in fasting, that is migrating motor complex, and also movements of villi. What are mixing movements? Mixing movements of small intestines are responsible for proper mixing of chyme with digestive juice such as pancreatic juice, bile and intestinal juice. The mixing movements of small intestine are segmentation, contractions and pendular movements. What are segmentation, contraction? Segmentation, contraction are the common type of movements of small intestine which occur regularly or irregularly but in a rhythmic fashion. So, these movements are also called rhythmic segmentation, contraction. The contractions occur at regularly spaced intervals along a section of intestine. The segment of intestine involved in each contraction is about 1 to 5 cm long. The segments of intestine is between the contracted segments are relaxed. Length of the relaxed segments is the same as that of the contracted segments. These alternate segments of contraction and relaxation gives appearance of rings resembling the chain of the sausages. After some time, the contracted segments are relaxed and relaxed segments are contracted. Therefore, the segmentation contractions choke the chyme many times. This helps in mixing the chyme with the digestive juices. Now we'll talk about pendular movements. Pendular movements is the sweeping movements of the small intestine resembling the movements of the pendulum of a clock. Small portions of the intestine, that is loops, that sweeps forward and backward or upward and downward. It is a type of mixing movement noticed only by close observation. It helps in mixing the chyme with digestive juices. Propulsive movements. Propulsive movements are the movements of the small intestine which pushes the chyme in the arboreal direction through intestine. The propulsive movements are peristaltic movements and peristaltic rush. What are peristaltic movements? Peristaltic movements are defined as the wave of contraction followed by wave of relaxation of the muscle fibers. In gastrointestinal tract, it always travels in arboreal direction, that is stimulation of the smooth muscles of the intestine initiates the peristalsis. It travels from a point of stimulation in both directions, but under normal condition the progress of contraction is in an oral direction is inhibited quickly and the contractions disappear. Only the contractions that travel in an arboreal direction persist. What is Starling's law of intestine? This is an important law frequently asked. Depending upon the direction of peristalsis, law of intestine was put forth by Starling. According to the law of intestine, the response of the intestine for a local stimulus consists of a contraction. See, this is the movements of intestine. Okay, contraction of the smooth muscle above and relaxation below the stimulated area. Peristaltic contraction starts at any point of the intestine, travels towards the anal end at a velocity about 1 to 2 cm per second. The contractions are always weak and usually disappears after traveling for few centimeters. Because of this, the average movement of the chyme through the small intestine is very slow, and the average velocity of movement of chyme is less than 1 cm per second. So the chyme requires several hours to travel from duodenum to the end of the small intestine. Peristaltic waves in the small intestine increases to a great extent immediately after a meal. This is because of the gastroenteric reflex, which is initiated by the distension of stomach. Impulses from this reflex are transmitted from stomach along the walls of the intestine through mesenteric plexus. Now, peristaltic rush. Sometimes the small intestine shows a powerful peristaltic contraction. It causes excessive irritation of the intestinal mucosa or extreme distension of the intestine. This type of powerful contractions begins in duodenum and passes through the entire length of the small intestine and reaches the ileocecal valve within a few minutes. This is called peristaltic rush or rush waves. Peristaltic rush sweeps the content of the intestine into the colon. Thus, it relieves the small intestine of either irritants or excessive distension. Now, what is peristalsis in fasting? That is migrating motor complex. Migrating motor complex is a type of peristaltic contraction which occurs in the stomach and small intestine during the periods of fasting for several hours. It also called the migrating myoelectric complex. It is different from the regular peristalsis movement because a large portion of the stomach or intestine is involved in the contraction. The contraction extends to about 20 to 30 cm of the stomach or intestine. This type of movements occur once a week, once every 1.5 to 2 hours. It starts as a moderately active peristalsis in the body of the stomach and runs through the entire length of the small intestine. It travels at the velocity of 6 to 12 cm per minute. Thus, it takes about 10 minutes to reach the colon after taking origin from the stomach. And the significance of peristalsis during fasting is migrating motor plexus complex sweeps the excess digestive secretions into the colon and prevents the accumulation of the secretions in the stomach and intestine. It also sweeps the residual undigested materials soon into the colon. Now let's talk about movements of villi. Intestinal villi also shows movements simultaneously along with the intestinal movements. It is because of the extension of small muscle fibers of the intestinal wall into the villi. Movements of villi are shortening and elongation, which occur alternatively and help in emptying lymph from the central lacteals into the lymphatic system. The surface area of villi is increased during elongation. This helps absorption of the digested food particles from the lumen of intestine. Movements of villi are caused by local nervous reflexes, which are initiated by the presence of chyme in the small intestine. Hormone secreted by the small intestine mucosa called villikinin is also delivered to play an important role in increasing the movement of villi. Now let's talk about large intestine. Movements of large intestine are usually sluggish movements. Still, these movements are very important for mixing, propulsion, and also absorption. Types of movements of large intestine. Movements of large intestine are of two types: mixing movement, that is segmentation contraction, and propulsive movements, that is mass peristalsis. Mixing movement, segmentation contraction, is large circular constrictions which appear in the colon are called mixing segmentation contraction. These contractions occur at a regular distance in colon. Length of the portion of the colon involved in each contraction is nearly about 2.5 centimeter. Propulsive movements or the mass peristalsis are the feces from the colon towards the anus, and usually this movement occurs only a few times every day. Duration of mass movement is about 10 minutes in the morning before or after breakfast. This is because of the neurogenic factors like gastrocolic reflex that is discussed below and the parasympathetic stimulation. Now let's talk about defecation. Voiding of feces, that is emptying of feces from the intestine out of the body, is called defecation. Feces is formed in the large intestine and stored in the sigmoid colon. By the influence of an appropriate stimuli, it is expelled out through the anus. This is prevented by tonic constrictions of anal sphincter in the absence of stimuli. There is reflex for that also, that is defecation reflex. Mass movements drives the feces into sigmoid or pelvic colon. In the sigmoid colon, the feces is stored. The desire for defecation occurs when some feces enter the rectum due to the mass movement. Usually the desire for defecation is elicited by an increase in the intrarectal pressure, which is about 20 to 25 cm of H2O. Usual stimulus for defecation is intake of liquids like coffee or tea or water, but it differs from one person to other. The act of defecation. Act of defecation is preceded by voluntary efforts like assuming an appropriate position, voluntary relaxation of extreme sphincters, and the compression of abdominal content by voluntary contraction of abdominal muscles. Usually, the rectum is empty during the development of mass movements. The feces is pushed into the rectum and the defecation reflex is initiated. The process of defecation involves the contraction of the rectum and relaxation of the internal and external anal sphincters. Internal anal sphincter is made up of smooth muscles and it is innervated by parasympathetic nerve fibers through pelvic nerve. External anal sphincter is composed of skeletal muscle and it is controlled by somatic nerves, that is, it is voluntary, which pass through pudendal nerve. Pudendal nerve always gives the external sphincter constrictor, and the sphincter can relax only when the pudendal nerve is inhibited. Gastrocolic reflex. Gastrocolic reflex is the contraction of the rectum followed by the desire for defecation caused by distension of the stomach by food. It is mediated by intrinsic nerve fibers of the gastrointestinal tract. This reflex causes only a very weak contraction of rectum, but it initiates defecation reflex. Now, pathway for defecation reflex we'll talk in the next chapter. And talking about the important points, the headings in red are always important. Just go through it. Now that's all for part 2. Applied physiology is what we discussed today. We'll continue with the part 3 in the coming video. Make sure you share your new informations and suggestions in the comments below. Thank you.